move on. Thank you very much. I guess you can hear me loud and clear, and you can see my screen as well. Just trying to highlight some few things that we said yesterday, and then we move on. Right. So, like we started by saying, we are only doing the basics of andrology, and to be able to appreciate andrology and both the semen analysis, you can better do that once you understand and appreciate the key elements of the male reproductive system. All right, so we try to take them one by one because we have some time on our hands. We don't need to rush, but try to make sure that we understand every aspect of the male reproductive system. So we looked at, we had an overview of the male reproductive system, looked at the penis, the testes, the epididymis, and then the general schematic overview. We have it as you have on the screen now. And we are just trying to take them one by one. And yesterday we said that if you look at the entire system, it's made up of organs. That's basics for any anatomy. The system is made up of organs, and organs are made out of tissues, and tissues are made up of cells. So for as long as you are talking about the male reproductive system, then you should be sure that we have a lot of organs to be dealing with. And it said that some of the organs can be found outside the body. And therefore, they are called external male reproductive organs. And for that matter, external genitalia. And we said that the key ones among the external reproductive organs are the penis, the scrotum, the testicles. We said that the testicles technically is a combination of testis and epididymis. They go almost hand in hand. And if you say the testis is different from the epididymis. If you say testicles, it is a combination of both. However, some people use them interchangeably, and I'm not sure that you get it wrong if instead of saying testes, you say testicles, or the other way around. Right. So we made some few points about the penis, and we said that technically it performs a dual function for sexual intercourse and also for urination. And when it comes to sexual intercourse, your main objective, apart from the pleasure, the main objective is to try to reproduce. All right, so for reproduction. So therefore, it becomes a reproductive organ. And for menstruation is also within the urinary tract. And so therefore, if you take the fact that it's doing the two things at the same time, then you can also combine that effect and say it's either a genital urinary organ or urogenital organ. It's the same thing, depending on which one you want to bring first. All right. And then we also said that if you read or somebody asks you what is the copulatory organ, then copulation is for sexual intercourse. The organ which is used in that is the penis, and therefore the penis can also be rightly considered as a copulatory organ. All right, so those are some of the highlights that we did yesterday. And we said that the penis has three parts, talking about the external structure. Okay, so we are talking about the root, the body, and then a glans. The glans is the last part, which is like a bulb. All right, so that's the glans penis, and then we have the body, and then the root. We don't need to waste time on that. Then we said that, of course, within the penis, you have the tract, or a tunnel, or a channel, or whatever you want to call it, and that is the urethra. The urethra begins from the bladder neck to the outside. And we said that because it is passing through some tissues, all right, then the part which is within a certain tissue, use that part to describe it. So therefore, we have the part which is passing through the prostate. So that part is the prostatic urethra. All right. Then you have the membranous urethra. There's that small portion between the prostatic and then the body of the penis. That small space called membranous urethra. And then the penis itself, the tract within it is the penile urethra. All right. Then we say that the opening at the glans penis, the opening is called the urethra meatus. An opening is, sometimes people say it's an orifice or just an opening. And so once you use the word meatus, meatus is any opening, okay? So if you say urethra meatus, you're talking about the orifice. Now, we said that urethra opening is a continuation of the skin. And therefore, since the skin is lined by stratified squamous epithelial cells, then it sounds to appreciate that the urethra within the glans penis is also covered by stratified squamous epithelial cells. All right, so it's in continuation of the outer skin. All right, and therefore that is how it is. And so we said that because of that, then it means that it is not very usual to get squamous epithelial cells in urine. Remember, we are saying that either the penis or the urethra performs the dual function for genitals and then also for urination. So it is not out of place to talk about urine even as we are doing semen or we are doing reproductive system. It is important, I said this again, that it's important to appreciate this because you can use this analogy to consider a certain urine to be from a male or from a female. If a male, normally we have epithelial cells in urine. It's very, very normal to have epithelial cells in urine. But you can look at the nature of the epithelial cells and try to see where it's likely to be coming from. So if you're seeing squamous epithelial cells, then ask yourself, where is it coming from? Knowing that squamous epithelial cells is only found within the glans, the urethra within the glans, the penis, that's the last part. And it is even stratified squamous, just like the one you have on the skin. When you have stratified squamous, it is said that it does not easily peel off. So if it doesn't peel off normally, and you are getting a lot of squamous epithelial cells in urine, then the question, where is it coming from? It is unlikely to be coming from a male patient. That's what I'm saying. So once you are having a lot of squamous epithelial cells in the urine specimen, your best bet would be that that specimen is coming from a female. And we say so because we say that when you look at the female, the vagina is lined by simple squamous epithelial cells, which, the squamous. The squamation, we explained that the squamous, D means removal, squamous, and mation is just the fact that it's just an expression of the activity which is carrying. So this squamation is removal of squamous epithelial cells. It's a natural phenomenon in the female. And so always you have the female tract renewing itself with fresh epithelial cells, and then old ones are peeled off naturally. And so once that is happening, it is very usual that you will find some of these squamous cells find itself in the urine. So all of us should appreciate that vaginal secretions can easily contaminate a urine specimen. And normally the example that I give to people is that if you consider the fact that after sexual intercourse, if a female produces urine, you will have a lot of sperms in the urine. The question is, did the sperm go to the bladder? Of course, no. The sperm went into the vagina, right? And the urethra is not part of the vagina as far as the female is concerned. So So the question is, if the sperm did not go into the urethra, and for that matter, into the bladder, yet it is finding itself in the female urine specimen, then it is only expressing the fact that secretions from the vaginal tract can easily contaminate urine in the that's why it is very common to find candida in urine specimen. Candida normally, candida is belongs to the fungal group, okay? And fungus are acidophilic. They love acidic environment. And you and I know very well that the vagina is highly acidic. In fact, the pH of the vagina is from 3.8 to 4.2, maximum 4.5. And you and I know that a pH of 4.5 is highly, highly, highly acidic. All right. Yet, that is the medium in which Candida thrives very well. So it is easy for a female to get candidiasis. All right. Now, if you are getting urine from a female who has vaginitis, okay, thrush, what we call thrush, or for that matter, vaginal candidiasis, it will easily get into the urine because secretions in the vagina will normally contaminate urine. And so if you have candida in urine, it doesn't mean that you have the bladder or the urethra has the what do you call it, the candida. It is not the case. Okay, candida will not infect the bladder unless you have seriously immunocompromised patients where you can have candida infecting the urethra and for that matter the bladder. But it is easy for candida to be found in the female. So all that I'm saying going round is that anything in the vagina can easily be found in the urine, and that is just simple contamination. And so if you are getting squamous epithelial cell, which is a normal cell which has peeled off in the vagina, finding itself in the urine becomes very normal. And that should tell you that that urine specimen you are looking at is not likely to be a male urine. That is a fact I want all of us to appreciate. All right. So you see that if you look at the male urethra, there's no squamous epithelial cells anywhere, but you appreciate that a lot of the epithelial cells we find in our urine is squamous. Now, sometimes you realize that you can occasionally get some occasional squamous cells in the male urine because right away you see that there is a little amount of squamous epithelial cells in the glans penis area, the urethra in the glans area. So occasionally, even though it is stratified, but if you're pushing out the urine, especially if it's forcibly, then of course, like trying to scratch your skin with your fingers. Of course, once you do that, some squamous epithelial cells, even though it is stratified, can be peeled off. So similarly, if urine is forcing itself through the penis, of course, there can be an occasional squamous cells coming off, but that's very, very occasional. Right? But I'm talking about the fact that there are many. If there are many, it is unlikely to be from the. I've gone round this. I want you to appreciate it once and for all. All right. As you move up the penile urethra, that is lined by stratified columnar epithelial cells, which will not peel off. As we move further up, we have the urothelial cells. And urothelial cells is what in school they tell us is the transitional epithelial cells. Transitional means they keep on changing their shape. And that is the nature of the bladder. You know, the bladder shape keeps on changing depending on whether it is full or empty, and depending on even how you walk, depending on whether you sit or not. The bladder shape keep on changing, and therefore you cannot get a fixed epithelial lining. The epithelial lining should be flexible, that can be changing here and there. So And because it's transition epithelial cells, it is lining the bladder, referred to as urothelium. I mean the epithelial lining of the urinary tract. So that's where you have it as urothelial cells. All right, and they will occasionally come out, and so you can get some. Sometimes you see them, you don't know whether they are what do you call it? As if they look like squamous cells, as better. Squamous cells is usually very large, broad, with a central nucleus. Normally, with the transition cells, they have a basal, what do you call it? Or what you call eccentric. The nucleus is not too much with the center. It's like pushed to the base a little bit. All those things are things that you help you to know that this is not squamous epithelial cell. It's likely to be a transitional epithelial cells, and since it comes from the urine, it's a urothelial cell, and it's normal coming from the bladder. And those cells that can come up to the prostatic urethral portion. All right, and therefore you must understand all this so that once you see a certain type of epithelial cells in the urine, you don't just write epithelial cells, but you can look at the nature of the epithelial cells and have an idea about where it is coming from. For example, if you look at, we are not doing a urinary tract per se, we are doing the genitals, and for that matter, the reproductive system. But let me just come in here with, let's say, cuboidal epithelial cells. Cuboidal epithelial cells are very rounded with small nucleus, and they are typical. And they normally line the ureters, not the urethra. They line the ureters. That is connecting from the kidney itself to the bladder. You know, you have the loops and so forth and so on. We are not going there, but just to tell them where the urethra is coming from. They are lined by cuboidal epithelial cells. And so if you're seeing cuboidal epithelial cells also in the urine, you should have an idea that they are coming from the ureters. And that means that there's a serious kidney injury. Okay? If you have what you call nephrotoxicities, if you're taking especially drugs that cannot be detoxified, you know that whatever you're taking that is toxin must be detoxified, and therefore is the function of the liver to detoxify anything which is toxin have to be detoxified, and then the kidney will now to excrete it. If the liver is unable to detoxify it, the kidney will have to excrete it at all costs, and so that it is like pushing acid into your basin. If you generate an acid residue and you don't neutralize it before you try to push it off, but you straight away the acidic state, you push it into your basin, then what happens is that you are going to cause some tear and wear within your basin, as simple as that. So if you have a product which could not be detoxified, yet has to be excreted, then through its excretion, it will cause some tear and wear and tear, or whatever you call it. Is it tear and wear or wear and tear within the ureters? Because it's like you are pushing some harshness into the ureters. And once they do that, they'll cause some injury on the linings of the ureters. And the lining of the ureters are cuboidal epithelial cells. So once you are seeing cuboidal epithelial cells in urine, it tells you that there's serious injury within the kidney. And once you just don't say that, oh, you report that the epithelial cells, they are normal. All right. If you say epithelial cells, they are normal, the doctor will also think that, oh, what are epithelial cells? These are normal in the urine. But if you take a quick look at it and say that these are cuboidal epithelial cells and therefore they are coming from the renal tubules, then they will have cause to look at the cause of it and then probably save the patient. Similarly, for example, if you have RBCs in the urine, all right, if you have RBCs in the urine and mostly you can think that, oh, these are probably due to schistosoma infection. But you can look at the nature of the RBCs, and if they are what we call dysmorphic, when you say dysmorphic, morphic is morphology, and for that matter, the shape. This is abnormality. So if you have dysmorphic albices, what it means that you are looking at some albices that have very weird shape. And once that happens, this is likely to be due to glomerular injury. All right. So as scientists, we have to be able to look at the morphology of the cells that we find in urine. So if you just say RBCs, then RBCs, they go, oh, if it's a female, probably is in a menses or something like that. There's some kind of contamination, blah, blah, blah. But if you say that these are RBCs which are dysmorphic, it gives a different interpretation altogether. So coming back, what I'm saying is that if you know the anatomy of the urethra, and you know the linings, the particular lining along the line, then if you are seeing cells, you'll be able to predict the source of the cell and then give a better interpretation to it as a scientist. All right. I think I've talked too much. Yes. Alter the shape of the scrotum. We said that the scrotum, as much as possible, it is trying to protect the testes. In protecting the testes, it's also trying to put the testes in a right temperature environment. As we move along, you realize that testis functions to produce sperms. Sperms are produced under specific temperature conditions. Those temperature conditions are lower than the body temperature. And that's why naturally, excuse me, the testis generates from the abdomen. It could have been allowed to remain there. But you and I know that the body temperature is around 7 degrees. Meanwhile, the optimal temperature for sperm production is around 34 degrees, which is about 3 degrees lower than. That 3 degrees is significant enough to cause infertility. All right, and for that matter, sperm malfunction or dysfunction. So don't say that, oh, just 3 degrees difference will not make anything, to make a lot of difference. So naturally, God, in his wisdom, develops the testes in the abdomen. But before delivery, the testes will have to descend through the inguinal channel and then into the scrotum. So the sac itself, they're talking about the scrotum sac itself, has its own muscle. Then the testis which is coming out also comes out with some of the muscles within the abdomen. All right, so that muscle is like it's like protecting it. So the muzzle comes out with it into the scrotum. So that muzzle can also contract. So we call that the cremaster muscle. So we have the dartus muscle within the skin itself. So we say it's subcutaneous because after the skin, underlining it, we have the dartus muscle. So we say that is subcutaneous. So when that contracts, it doesn't affect the testis itself. It only affects the shape of the scrotum. So for example, once it contracts, then it will cause the scrotum to shrink. Once it shrinks, how will you see that it has shrunk? When it shrinks, you see it's wrinkled. Once it wrinkles, that means that it is reducing the surface area. Once it's reducing the surface area, then it means that if there's a heat loss, the amount of heat that will be lost through a wrinkled scrotum will be less. And so what it means is that, if the environment is cold, you find yourself in a cold environment, your testes will shrink. So I'm talking, the scrotum will shrink. I remember a colleague who said that the first time he went to US, and every morning will just feel the scrotum as if the scrotum is gone. It will shrink because the cold environment, the scrotum has an obligation to protect the testes to maintain a certain temperature. If the temperature around in the cold environment is too cold, then it means that the datus muscle should shrink. Sorry, should contract. Once it contracts, it shrinks the scrotum. Once that happens, then it means that once it has shrunk, the surface area is now very small, and therefore the amount of heat to be lost will reduce, and therefore it retains the heat to maintain the temperature of the scrotum above the environmental temperature. So those things are very, very physiologically normal. So that, and if you get yourself in a very warm area, then the muscle will now have to relax. Once it relaxes, then it will allow the scrotum to have a smooth area. Once you have a smooth area, it means that it's increasing the surface area. Once it's increasing the surface area, then it's allowing more heat to go off. Once more heat is going off, then the temperature within the testes will also become lower. These are simple things. You talk about them when you deal with the physiology of some of the organs within the reproductive system. But this is just a simple explanation to how the scrotum can change its shape and size to maintain the optimal temperature for sperm production. Right. So this is all that I've tried to explain. So the cremaster muscles and then the datus muscles, you should know where they are. The cremaster is with the muscle that is attached to the testis itself, and it came along with it from the abdomen. All right. And then the datus is the one which is also lining the undersurface of the skin of the scrotum. They work hand in hand. All right, they work simultaneously. So, or if all the two begin to, let's say, contract. If the two contract at the same time, one, the contraction of the cremaster muscle will now pull the testicles closer to the body. You know that because the cremaster muscle is directly in link with the, let me take you to, yes. The cremaster muscle is directly in link with the testis itself. So the question, if it contrasts, as it contrasts, it pulls the, excuse me, let me try to see if I can use some annotations here. I'll start to see if I can get some annotations, and as usual, I'm having a challenge. Okay, so, right, I hope you can see that. So if this muscle, the cremaster muscle, contracts, it will pull the testis closer to the body. Okay, once it pulls the testis closer to the body, then it means that the environment is cold. Once the environment is cold, then the temperature in the testes have to as much as possible to become warm. So it will pull, the cremaster muscle will contract and pull the testes closer to the body. Once it pulls the same time, the datus muscle, which is in the skin here, will also cause the scrotum to shrink. Okay, once it's shrinking, then it is causing less amount of heat to leave. So at the same time as the cremaster muscle is contracting, the that tooth will also contract, or in attempt to keep the testicles warm. All right. So those things are very, very important to know, because sometimes as scientists, somebody can explain to you, oh, it's like my testis is almost gone. Oh, I cannot feel it. Then you have to explain, oh, if you're feeling cold, that's what happens. It's a physiological phenomenon that will try to protect the temperature of the testicles. So it is normal. All right. So that's good to go. Right. So we've explained this one already. Yes, yesterday we also mentioned that, and I've said it, the testis is developed in the what do you call it, in the abdomen, and then about 2 months before birth or shortly after birth, it will have to descend through the inguinal canal. I'm sure you all of us know the inguinal canal. Okay, that's why it is common for males to have inguinal hernia. And hernia is just a loose area where within the abdominal tract, where any force within the abdomen will push the intestine into that weakened area. All right. So because the inguinal area, the testis will have to push itself through to it to descend into the testicles. Even though after pushing itself through that, it will seal off. But once an area has been damaged, so to speak, and sealed off, with time it can still weaken. So that is how it is. So because the area has been weakened before, with time, if you have somebody, and of course other predisposing factors are there, then there's a likelihood of that area to weaken again, so that the intestines will now, especially if you have some pressure generated within the abdomen, then the intestine will try to push itself through the inguinal canal, which, because of the penetration of the testis through that at the time of birth, and that place has become weak, then it gives way for the intestines to find space there. So that explains why there are more men with inguinal hernia than women, because women don't have testes. For that matter, there is no push through the inguinal canal, as we are trying to explain here. I'm sure the explanation is well noted. Right. Right. Let me also make this point. Usually, I don't know whether I said this yesterday, usually the left testicle lies lower than the right testicles. It is normal, even though in some people it is the other way around. But we are talking about usually. So it means that it's more common for the left testicles to be lower than the right testicles. Once one is lower, it means that that one is heavier. Okay, because the thing is hanging. So if two things are hanging, one is heavier, then of course that the heavy one will move a little bit down, lower than the one. The explanation they give to that is also natural, because you see, God is in his wisdom. If you have the two testicles lying on the same plane, side by side, the tendency is that there will be pressure from each side. I mean, even if whatever you do, you see that there's going to be that kind of friction, because they are all the same line. They are all like two balls on the same line. But if one is lower and one is up, then it lessens the tendency for any friction. So God is so wonderful. So what I'm saying is that it is normal for one testicle to be lower and one above. It is very, very normal. So sometimes if you don't have this information, you have a patient who complains to you, oh, doctor, I said, I said, it is normal, very, very normal. And like I've said, it is more common for the left testicles to be lower than the right. but occasionally you can have it the other way around. Okay, so you must get that information so that you don't once you yourself are educated, you have that knowledge. If somebody complains to you, you'll be able to know how to explain to that individual. You've also said that the testis is outside the body because the temperature inside is not favorable for sperm production. At the end of the day, the major preoccupation of the testis is to produce sperms. All right. So sperm production occurs at specific temperature, period. All right. So if that, that temperature is supposed to be lower than the body temperature, then God in His wisdom will have to bring it outside. And it brings in a regulatory mechanism to the scrotum. And we have talked about how the scrotum can regulate the temperature depending on the environmental temperature. If the environment is too warm, how the scrotum will react. If it is too cold, how to react. So that is the nature, and it's important to note all those things. We said this since yesterday. And then when it comes to the testicles, or for that matter, the testes, yesterday we talked a lot about it. And then we said that the testis itself is lined by a connective tissue called the tunia abugenia. And this tunia abugenia tries to invaginate, is to create segments. And I try to use the orange as an example. If you peel the orange, you see that the covering appears to be pushing itself into the inside of the orange, so that you can pull it off segment by segment. Okay, just that is how the testis is, and each of that segment is called a lobule. Now I'm saying that lobule, the word ULE, it means small, tiny. So lobule is a tiny lobe, just as you have tubule. So a tubule is also a tiny tube, as simple as that. All right. So those are the things we tried to explain yesterday. And we said that on the average, you have about 250 lobules in each testis. And it's ranging between 200 to 400 lobules. All right. And for each lobe or lobule, I'm sure you know the difference between a lobe and a lobule, a tube and a tubule. All right. So even if I make a mistake and say lobe, I'm sure that you know that you're talking about a small lobe, and therefore becomes a lobule. Right. Each lobule has about 3 to 10 coiled tubules, so small tubes. So you can imagine that you have a tube, and I want to just use your knowledge about any small tube. For example, the one sometimes you use in our labs as a tourniquet, the transfusion, how do you call it? The transfusion, blood transfusion connecting this thing set. I'm sure a lot of us use that one for our tourniquet. All right. So if you have a tube like that, you try to coil it. Okay. If you try to coil it, so you see that as you try to coil it, I wish I could. I'm not too good at this. I wish I could use some design too, but we are all matured. I'm sure you can follow what I'm trying to talk about. So use your tourniquet, not the tourniquet as in the proper tourniquet, the blood transfusion type, the one that we use. You use that as figuratively, and then try to be coiling it up and down. As you coil it up and down, you see that for each coil that you make, there's a space. All right. So that's how the seminiferous tube is. It's a long tube which is coiled. So within the tube, okay, there are cells. And then outside the tube, as you coil it, outside the tube, as you coil it, there is a connection. So you call that is also a connective tissue. So the tube, you have a long tube which you are coiling it, and as you coil, for each curve there is a space, and that space must be filled. Something must connect it, so that's a connective tissue. So you have a connective tissue, and then you have the tube itself, the inside of the tube itself. If you can imagine this one, you will understand this very simply. So that is how the let me see. That's how the testes look like. So you have the tube here, which is coiling itself. And so within, for each tube, there is also a space here. And that space is the connective tissue. All right. So within that connective tissue, there are also cells in there. So there's a connective, this called a connective tissue cells. And then we have some within the tube itself too, there are also cells there. Those cells too are called Sertoli cells. So I'm saying that one of the simple ways to remember, I wanted to, yes, let's see here. I wanted to find a place where you can get it easier. Okay, so within the tube, we have Sertoli cells. So the tubes are called seminiferous tubules. And tubules because they are small. So seminiferous tubules. Within them, you have special cells called Sertoli cells. All right, so and they are within the cells. And within the cells, we also have germ cells. Germ cells are undifferentiated cells. Okay, and they are called spermatogonia cells. They are spermatogonia because they are the cells that are going to eventually produce the sperm cells. Okay, so within the tubule, we have the Sertoli cells and as well as the germ cells, which we call as spermatogonia cells. So you must understand that. Then outside the tubule, you know, the tube is connecting. So outside the tubule, you are going to have the connective tissues. And then within the connective tissue, you will also have Leydig cells. All right. You need to understand this very, very well, because if it comes to when we get to the hormonal controls, you should understand these things, and then you appreciate why, for example, testosterone levels are usually low in serum or in the blood in the bloodstream. Why do you have testosterone? Meanwhile, we want to appreciate that testis produces testosterone. But if you look at the level of testosterone in the what do you call it? In the bloodstream is usually low. And you should be able to understand some of these things. The reason is that if assuming, okay, not assuming, this is the cross section of the testis. We are talking about the tubule, which is the seminiferous tubules. So within the seminiferous tubules, we have here we have the germ cells. In between the germ cells, we also have the Sertoli cells. Then you see that as you are coiling the tubes, this is one tube and this is another tube. There is this space. So this space becomes the connective tissue. Within this connective tissue, we have Leydig cells. It's the Leydig cells that will produce the hormones, testosterone. So you see that the Leydig cells are produced from here, but for every hormone, they must have a target, a receptor, okay, receptor cell. The receptor cells for testosterone are on the cells within the tubules here, the Sertoli cells. So if the hormones are produced from here, and their target cells are here. Why must they go into the bloodstream? They won't go into the bloodstream. If they go into the bloodstream, then it means that they have overproduced and you have very little. So you have about 100 times of the testosterone within the testis itself, because they are produced just here, and this is where they are needed. So that is as simple as that. So these are the things that as scientists we should understand and appreciate, so that if you are talking about andrological disorders, you are talking about semen analysis, you will have a better understanding of it. All right.
Grandpa.
We said this, I think we discussed all this yesterday. I'm just trying to recap for the benefit of those who couldn't hear me properly, and for the benefit of those probably who are also joining us today and couldn't join us yesterday. All right. Right. So another schematic representation of what we are saying. So we have these bigger cells are the Sertoli cells. Okay. And this whole thing is the cross-section of the seminiferous tubules. Okay, so we have this one. These are the germ cells, the germ cells. So it is these germ cells which will be dividing and dividing and dividing and getting to become the sperm cells. Yeah, of course, we're going to talk about spermatogenesis, how the sperms develop and so forth and so on. Right, so these are the Sertoli cells, these big cells. They produce a lot of things, I mean, nutrients that will feed these cells. They feed these cells. And because they feed these cells, they are also called the nesting cells. It's like a nesting mother, all right? So without these cells, germ cells cannot be developed. These germ cells will be there, but they cannot develop to become the sperm cells. So these sperm cells are going to provide the nutrients and everything that these ones will need to develop. So, of course, without sperms, without the Sertoli cells, there will be no sperm cells. And these Sertoli cells that also have the receptors for the androgens. And when you're talking about androgens, you're talking about the male, remember, andros, and I met some people who are already beginning to call me andros, because yesterday I said andros is orodros, and therefore is the man. Okay, just to make you appreciate and then understand some of these things better. So they have what they call the androgen binding proteins, and androgens are the male hormones, and the male hormones are testosterone. So of course, these ones, they hold the receptors. And within this space, you see that this is here, and this is also here. These are all the seminiferous tubules. So within this space, because this is a tubule, this is also a tubule, we call this space intertubular space. Intertubular. And the cells here are intertubular cells. And these intertubular cells, especially, are called Leydig cells. These Leydig cells are the ones that produce testosterone. And because for these ones also to produce the testosterone, they also need some hormones. And just as a brief, because we are going to talk about them in details, they also hold receptors for luteinizing hormones, LH. So you need the LH for these Leydig cells to produce the testosterone. And once the testosterone are produced, these also have the receptors for testosterone, so they also move in here. So you will see the link between the LH, Leydig cells, and then the testosterone production. You understand? So you talk about it, but I want you to have an idea about the anatomy or the structure of all these things. So as we move along, we can appreciate them more. All right. So like I said, Sertoli cells are also called supporting cells, like I said, because they produce the nutrients for to nourish the germ cells to develop to become the sperm cells. So they are called supporting cells. They are also called the nesting cells because they nest. It's like they are feeding the germ cells. So sustenticular, to sustain. So it's the same thing. So, and then sustenocytes. So it's a cell that's sustaining another cell. So all these things mean the same thing. Sertoli cells, supporting cells, nest cells, sustenticular cells. Hello, I'm sorry, my connection went off. Sorry once again. Just to say that the the testis, the structure of the testis is important to us as scientists to be able to understand the physiology of um, of andrology. So the entire andrology concepts. I forgot to also add that the LH, let me go back a little bit and then uh, see if you can, yes. So you just trying to look at the internal structure of the testes. And I'm sure that I asked you to use a small tube like the one we have adopted as a tourniquet in our labs. At that small tube, and try to winding it up and down. As you wind it up and down, you see that for each coil that comes in, there will be a space. And that space is connecting one aspect of the coil to the other. Okay, so that is, so if it's a tube, then that space is intertubular, in between the tubes. So that's intertubular space. All right. Now, so you see that within that space, it also forms a tissue. All right, because you are going to get multiple cells, and as soon as you get multiple cells, we are talking about the tissue. So you are going to get a set of cells within that intertubular space, and there are also certain cells within the tube itself. And we say that the tube itself is called a seminiferous tubule. And within the seminiferous tubule, we have two types of cells. The first cell is called Sertoli cells. And the Sertoli cells, I've said that they have numerous names because of its role. Now, the Sertoli cells is there with germ cells. Germ cells are it's like the stem cells, okay? Or the undifferentiated, if you do take us back to our hematology, hematopoietic cells. You see that you have a germ cell or a stem cell. That's the parent cell that will be developing and produce. So we have that germ cells, which we call the spermatogonia cell, and then we also have the Sertoli cell, all of them within the tube or within the tubule. All right. So we are saying that those germ cells must be fed, must be nourished before they can continue to develop to become the mature sperm cells. It is this Sertoli cells that will provide that nourishment. And because they are providing nourishment for the germ cells to now become mature sperm cells, they are given a lot of names, all to explain the, I'm trying to go to that side and then. So we call the Sertoli cells supporting cells, nest cells, sustenticular, sustaining. So that's all, or sustainable cells. This cell, just to tell you the function of the Sertoli cells, that the cell itself that will give you the sperms are not the Sertoli cells. They are the germ cells, which we call the spermatogonia cells. I hope that point is very, very clear. Good. Then we went on to say that I just want to see if good. I'm saying that if you take a cross section of the testes, when you have a tube and you take a cross section of it, this is what you're going to have. All right, so this is one tube. And within the tube, you have this as, let me see if I can go back and get you the annotation. Okay. So this is the, if you take the cross section, this is the tubule, one tubule. This another tubule, of course, because of diagram. So this another tubule, this another tubule. So if you have a tubule here and a tubule here, there's going to be a space in between them. And within this space, because it is in between tubes, we call it intertubular. Intertubular. And within that intertubular space, there are cells. Okay. And these cells are either called intertubular cells or interstitial. You know, interstitial is just in between spaces. Interstitial is a space between two things. That's all. So we either call it intertubular cells or interstitial cells. It is these interstitial cells which we call Leydig cells. Okay, Leydig cells. And I'm saying that these Leydig cells are the ones that produce testosterone. Okay. Now I'm saying that before they can produce the testosterone, they also need hormones. And the hormones that will trigger the production of the testosterone is the LH, luteinizing hormones. And I'm saying that you can link the LH and then the LADIC so that you don't confuse. So that's why I'm saying that even the seminiferal tubules, S here, the Sertoli cells, okay, right? So that there's some S and S. If you go, as we move along, we are going to talk about the follicle stimulating hormones too. There's an S there. So follicle stimulating hormones too will work within the seminiferal tubules because of their S. I'm not saying because of their S, but you can use that one to link and help you. So if you're talking about follicle stimulating hormones too, they will never work here. They will never work here because the receptors for the follicle stimulating hormones are also within the seminiferal tubules. Okay, so they will come here. The follicle stimulating hormones will also work on the Sertoli cells, okay, to help produce the nutrients for the germ cells to now begin to develop. Then I'm saying that within this intertubular or interstitial space, the cells there are what we call the Leydig cells. All right. So I'm saying that these Leydig cells, too, before they can produce the testosterone, they have to get some hormones, and the hormones will be the LH, luteinizing hormones. So you can link the L there and the L here. And I'm saying that there is another terminology associated with LH, and I want to see if I can get it for you. The lady said, very good. You see, this is, if you look into certain textbooks, you can see ICSH, this interstitial cell stimulating hormone. Interstitial cell, and we said that interstitial cell is the same as intertubular cells. The intertubular cells are the Leydig cells. And we said that before the Leydig cells can produce their testosterone, they have to get the hormone. What hormone is that? That's the Leydig, sorry, the luteinizing hormones. So the luteinizing hormones must stimulate the Leydig cells to produce their testosterone. And therefore, if you link them together, you see that the Leydig cells can be called like interstitial cell stimulating hormone. So if, let's say, you're in a lab and you get some doctors who probably know about or will write ICSH instead of just writing LH, as a scientist, you should be able to know that LH is the same thing as interstitial cell stimulating hormone, because the interstitial cells, they have the Leydig cells. The Leydig cells will have to be stimulated by luteinizing hormones to be able to produce their testosterone. I hope the point is not clearer. The person who wanted clarification on the Leydig cells. The Leydig cells are the cells that are within the interstitial space. I'm sure that is clear. So the cells in the interstitial space, which we can call interstitial cells, they are called the Leydig cells. Okay, right. So whichever way you look at it, interstitial cells or Leydig, they are the same thing. Just as Sertoli cells are the same thing as nesting cells or the sustenance cells. Same way, interstitial cells are also the same thing as the Leydig cells. And the hormones that will trigger it to produce the testosterone will be the LH, luteinizing hormones. So you can link the Leydig cells and then the luteinizing hormones, L and L, just as you can have FSH and then the Sertoli cells. All right. I hope my point is clearer now. All right. So I'm sure we can move on now. So that's a brief about the testes and their internal structures. And once you appreciate that, let me go back again and then make a certain clarification here. You see that this is black capillary, okay? blood capillary. Now, I was talking about the tight cells, tight junctions. These Sertoli cells, they link themselves together to produce what we call the tight junctions. You remember that we have tight junctions in the CNS, the cerebral, what do you call it? Central nervous system. So that we have the blood-brain barrier, said that certain things within the blood cannot cross into the CNS, and for that matter, into the CSF. All right. So, and it is as a result of tight junction. If you have cells that are tightly bound together, they will not allow macromolecules to cross over. The same way, these Sertoli cells, they are also protecting these germ cells, and they rather produce tight junctions. They link, even though because of diagram you are seeing them like this, but they link to each other in a very tight manner. So they form tight junctions. And once they form tight junctions, they will not allow anything, macromolecules within the blood here to cross over. So there is this testis blood barrier. I hope that somebody's getting me right. So because if they don't take care, you see, as we move along, you realize that the sperm cells is a haploid, isn't it? It's a haploid, meaning that the chromosomes in there is what? Is 23. You know that normal chromosomes will have 46 chromosomes. Normal cells will have 46 chromosomes. This one has 23. All right, it has been halved. And because of that, it becomes like a strange cell for the body. The body doesn't know cells that have 23 chromosomes. The body knows itself to have 46 chromosomes. So if you are now having another cell that has 23 chromosomes, this will be alien. And therefore, the body will have to attack it. The immune system will have to attack it. It becomes alien. So you have these tight junctions to ensure that the Sertoli cells, that's why Sertoli cells are very, very important. They are protecting the sperms, the germ cells. You see, so if they don't take care and they allow access of the blood here to get access to this, then all this is the sperm cells will have to be attacked. Right? So the Sertoli cells will form tight junctions, and once they form tight junctions, it forms a barrier that will not allow macromolecules and for that even bacteria or any larger molecules to cross. So there is a tight barrier there. You call it the testicular blood barrier. All right. And that's very, very important. If it's not, so that if there's an injury, anytime there's testicular injury, okay, then there's a likelihood for the tight junction here to be broken. Once it's broken, then the antigen, this one was the cells now will serve as antigen, and you have access, the blood immune system will have access to it and to attack it and to produce what we call anti-sperm antibodies. We are not going to, as we move along, we're going to move there. But what I'm saying is that you should get this concept from here, that this, what do you call it? Sertoli cells are very, very important. Apart from nourishing the germ cells, they're also protecting they are also protecting the germ cells, said that they will not have access to the bloodstream. Okay, so that the immune system will not attack your sperm. It can only happen if there's an injury or if there's what do you call it, any surgery that compromises the testicular integrity. Then, of course, you are going to have sperms. The sperm antigen will now go to serve as an alien, a foreign agent, and then the immune systems will produce anti-sperm antibodies and then begin to cause a whole lot of mess. So that must also be noted. I'm saying that these are fundamentals which you must understand so that as we move into the advanced stages, you can appreciate all these things. Right. So the tight junctions are caused by the Sertoli cells, and they cause blood testis barrier or testicular blood barrier, whichever way you want to look at it. And this is similar to the blood-brain barrier, all right? So that once there's this barrier, antibodies, antigens, anything, will not get into the testis, all right, to destroy the sperm cells. Because like you know, sperm cells are alien because of one fact, that sperm cells are haploid. Haploid means that they don't have the full complement of the 46 chromosomes. They have 23, and therefore, technically, they are alien to the body. And if there's no protection, the body immune system will attack it. Right. So I think we talked a lot about the Sertoli cells. We also said that Sertoli cells, they also have the receptors for the follicle stimulating hormones. As you move along, you know where follicle stimulating hormones will be coming from the anterior pituitary glands. All right. But when they come, wherever you have hormones will have targets. All right. Based on which tissue have the receptors. So the receptor for follicle stimulating hormones are within the Sertoli cells in the seminiferous tubules. So they will just go straight into the testicles and will hit the seminiferous tubules and then go to the Sertoli cells because that's where the receptors are. All right. And then once the Sertoli cells have these hormones, then they will be now motivated to produce the nourishment and all those things that will help the germ cells also to develop to become mature sperm cells. The Sertoli cells also produce another of hormones we call the inhibin. Inhibin means it will inhibit. All right, we'll talk about all these things later in the advanced stages, but I just want you to understand that the Sertoli cells plays very, very key role in your and my maleness. And your maleness and my maleness is the fact that you're able to produce sperms that will now cause us to also reproduce. All right. So the Sertoli cells are they are the cells that is protecting the germ cells in several ways and also supporting it. And they will have a means of also regulating itself. One of the means is to produce antibodies, hormones we call inhibin. We'll talk about that in the next stage. But I just want you to understand the role of the Sertoli cells, the role of the Leydig cells, and how they interact. So when you read the slides, with this kind of explanation, you can appreciate it better. Right. So ABP is the androgen binding proteins, and they are produced by the Sertoli cells. And I'm saying androgen, when you talk about androgen binding proteins, what are you talking about? Androgens are just the male hormones. Male hormones are the testosterone. Okay. And we said that the testosterons are produced by the Leydig cells. The Leydig cells are outside the seminiferous tubules, but the receptors are in the Sertoli cells, and they are there as proteins. Receptors are proteins. So, and they are not called testosterone receptors. They are called androgen binding proteins, ABP. Androgen binding. So when we talk about androgen binding proteins, we are talking about receptors for testosterone. Receptors for testosterone, and they are within the seminiferous tubules, specifically the Sertoli cells. Right. So I think I'll try to explain that a lot of time testosterone is not high in the bloodstream because they are produced by the lady cells in the testes, and they're also used up by the Sertoli cells also in the testes. So it's like they don't have too many of them to be left into the bloodstream. So that's why. So you have a lot of the testosterone concentrated within the testes and not in the bloodstream. As scientists, you should appreciate this one. So there's sequestration of the testosterone in the testes and not in the bloodstream. Right. So I think we've done a lot of talk, and all these things is just an it's like over elaboration of what we did yesterday. Right. So we are moving to another organ, the epididymis. Epididymis, like the testes, is also paired. And yesterday I tried to explain that if you are talking about testes and you say TESTIS, you are talking about one of the organs, one, but they are paired. So if you want to talk about the two of them, they become TESTS. That's the plural for testes. IS is singular. ES is plural. The same way epididymis here. IS is singular, and ES will also be plural. So it depends on so if you are writing and you write epididymis ending ES, you are talking about the paired organs, the pair of them. All right, so that's the difference. So like the testes, they are also paired, and they are also located within the scrotum. Right. It is in close contact with the testes and descends with the testes into the scrotum. So we have said over and over again that the testes are developed in the abdomen. All right. So the epididymis is also part of the structures within the abdomen that are descending. So it's like father and son. I mean, they are in close proximity, and then they come just like that. So that is what it is. So the epididymis consists of a long, highly convoluted tubule. And remember, we talked about a tubule and a tube. So it's highly coiled, that's the epididymis. And it is between 4 to 6 meters. You know, I think if you look at the average man is about, let's say 1.6, it's not even up to 2 meters. So for the epididymis to be as long as 4 to 6 meters, that's really, really long, but it's coiled. It's quite heavily coiled to the extent that you see that the smallest thing. But if you have to stretch it out, it is up to 4 to 6 meters, which is in feet from 13 to 18 feet long. So that is a really, really, really long duct. So, and then like we said, it lies above the testis, and it can be divided into 3 parts. It has a head, a body, and then a tail. All right. So the epididymis has a head, a body, and then the tail. The head is the proximal, the uppermost part of the epididymis. So that lies on top of the testis. So if you are talking about the testis, now you're talking about it's made up of tubules. So the tubules at the point or anastomose. When you say anastomosis, you're talking about joined together. All right. So if you say that these things have anastomose, that means that they have been joined together. If in some surgery you can have anastomosis, sometimes they say end-to-end anastomosis. What it means is that if, let's say, you have some let's say some lesion within, let's say, within the intestinal tract, they can cut one end of the intestine and cut another end and then join them. So the joining becomes the anastomosis. All right. So what we're saying that you realize that the internal structure of the testis is made up of a lot of tubules. All right. So as they move along, then some of them will join the other, that's the anastomosis. All right. So as they move out of the testis, then a lot of them will have joined together and then now form another structure we call the epididymis. So that's initial portion become the head, and it is very large. In fact, it's the largest of that portion of the reproductive organ we are talking about. So that's the epididymis, that's the head of it. So it is formed by the efferent tubules. I'm sure all of us know about when we talk about efferent and afferent. Okay. So the efferent tubules, remember we said that within the testicles, you have a whole lot of tubules, then they are merging, and then it's like the end of the exit. If you want to, for purposes of mnemonics, I'm sure you know mnemonics, that will help you to remember something. Efferent is exit. It's something to help you to remember. Efferent is exit. So it means that as the tubules begin to exit. All right. So the exit of the tubules within the distance is the beginning of the epididymis. I hope that makes sense. So it is formed from the efferent tubules, the tubules that are exiting the testes. I hope it makes sense now. So when we talk about efferent tubules, you are talking about all the tubules within the testicles that are so many of them that are merging, anastomosis, and then becoming, and then exiting. So as they are exiting, we call the efferent tubules. So the exit is also the beginning of another organ, and that's the epididymis, and that's the head of it. All right. And then the body, the other aspect of it, the other side, which is the coil portion, coil, that becomes the body, right? So I'm sure this is also very simple. Then the last end becomes the tail. So the tail end is also now become the smallest part of the epididymis. And that is also just as the efferent tubules is the beginning of the epididymis. Similarly, the tail end of the epididymis is also the beginning of another organ, which we call the vas deferens. All right. Okay. So when the sperm cells are formed within the, like by now you have you can conceptualize that the sperm cells are produced from the seminal tubules. The tubules will come then come to the efferent tubules. All right. And now they are coming, they will now push into the epididymis. Within the epididymis, a lot of things will happen. All right. So, but just to tell you that we are now going to look at what happens within the epididymis. It's very, very, very important. Very, very, very important to know what happens within the epididymis. So this is just a structure of the epididymis in pictures. So like, if you look here, I'm sure now you have a lot of idea about the seminiferous tubules. So this is the tunica abdominis, which is the covering of the testes, and then it invaginates. It pushes itself within to form the lobules. Okay, so these are the lobules here. This is the lobules. And within the lobules, we have the coiled tubule, the seminiferous tubules. And within the seminiferous tubules, you have the Sertoli cells and the germ cells that will work to produce the sperm cells. The sperm cells will now, you see, so all these tubules are now merging, anastomosis. So they will merge here to give you the efferent tubule, efferent exiting, efferent exit. So these are the exiting tubules. So they exit here and then here enter into the head or the proximal section of the epididymis. So all of them here, all the numerous tubules here will now put themselves into the head of the disease. So this becomes the head of the epididymis, and this is the body. This is not a one smooth thing. This is coiled. Remember, we said we are looking at between 13 to 18 feet long. So this place is tightly coiled. So it's not a smooth thing at all. So this is the body of the epididymis. And if you stretch it out, you are going to get about 18 feet long. All right. And then this is the tail of the epididymis, and of course becomes the beginning of the vas deferens. Very, very simple. Now within this space, epididymis, from the head to the body to the tail, what happens? What happens here and here are about the same. That what happens here is completely different. We are going to look at them before we close for the day. So here, the efferent tubules will push the sperm cells. Once the sperm cells are produced here, they are sent to be immature. Remember, I've said that you take spermatogenesis on its own. So I'm just mentioning them, that you go through how the germ cells will now, how they will divide, the meiosis and the mitosis, everything, and how they become sperm cells. Now, once they get here, they are still very, very immature. All right. So here is where they go through maturation stages, maturation. So here, the sperms that are here, they are sperms, all right, but they cannot move. They don't have ability to move. And so therefore, they tend to be immature. There are a lot of deficiencies in it. So they have to go through some schooling here to become mature. All right. So that is that. So let us see the role of the epididymis, and you end on the epididymis. As we said, the epididymis is a long tubule which is coiled and made as if it is short. It can take up to 14 days for a sperm to move from here to here. From here to this end can take about 14 days. So see that it's a long journey. All right. Good. So the function of the epididymis is to bring testicular spermatozoa that are non-motile, incapable of fertilization to functional maturity. What it means is that the sperm that are produced and come to the efferent tubular area will be pushed into the head of the epididymis. At that point, they are immature, and to the extent that they can't even fertilize. All right. So they will have to go through process of maturation. There are a whole lot of things that can happen within the epididymis. So, of course, they must be nourished. If you want something to grow, to mature, you must nourish it. And then, of course, it must also be protected. So the epididymis provide protection, provide nourishment, and then goes through a procedure of maturing the sperms. And I've said that these are just the introductory lessons. You them the whole topic of spermatogenesis will look at all these things in details, and also to the advanced level. And so once it has matured, they may be stored. So What it means is that the and also all the to protect it from harmful substances and so forth and so on. So all these things will happen. And it is important to note that from here, we move to another stage of the vase difference. So you will continue from here. Tomorrow, we look at the vase difference. Then you go to the other accessory organs, you go to the prostate, go to the seminal vesicles, bobo-uterine glands, all those sort of things, all those organs that contribute to the male reproductive system. You take them one by one, and when you finish, then you look at the certain important roles. For example, you come back to the penis, you look at how erection takes place, what goes into erection, and then what will happen if there's more function, all those sort of things. So, and all those things are part of andrology. Then so by the time we get to the third and fourth week, then you'll have learned a lot. Then we move on to the semen analysis component. Thank you for the day. If there's any question, if there's something you don't understand, either you speak and then I can respond, or you can put on the platform. Thank you. Yes, sir. Yes, sir. All right. I'm trying to see the questions. Can multiple ejaculation break the barrier of the Sertoli cells? Because I've heard a lot of myths about that. All right. So as far as I know, no. I mean, see, the things that are likely to break the barrier mostly is through injury, trauma. And the trauma can even be through surgery. All right. If there's any surgical, not necessarily within the any manipulation within the testicular area, okay, can damage the testicular structure, and then of course the Sertoli cell, the junction can be compromised. So I don't know about multiple ejaculation as a cause of no. Well, I mean, but of course we will do when we do the semen analysis, we are going to talk about ejaculations and how they happen and so forth and so on. But as far as I know, of course, I don't know everything. But as far as I know, multiple ejaculation will not cause the barrier, Sertoli cell, for that matter, the testicular blood barrier to be broken. What I know about is traumatic. Anything, and traumatic, it could be, if let's say, how do you call it? It could be if you have some accident and anything that can put some pressure on the testicles. That one I know. It can cause some testicular damage, and if there's a doctor is operating in your abdominal area and accidentally there's some kind of inadvertent cut in the testicle area. You can, so any damage. You see, and once that happens, the problem is that once that happens, there's a contact between the blood and then the testicle itself. I'm not talking about the structure. I mean, I'm talking about seminiferous tubules, because that's where you have the germ cells. Once there is a sense of the germ cells, the antigens, into the bloodstream, the body begins to produce antibodies. And for that matter, the antibodies, as for that one, the antibodies will be there for as long as you can think of. And that can cause a lot of infertility. And that is the anti-sperm antibodies. All right, anti-sperm antibodies is one of the major cause for what do you call it, infertility. And that can only happen when there has been a testicular trauma or damage in the testicular area, which compromises the Sertoli cell, or for that matter, the testicle blood barrier. I've made my point clear. I'm saying I don't know everything, but the little I know is that it is unlikely that multiple ejaculation can cause the barrier to be broken. It's not a small barrier. It's not a barrier that, no, it will not happen. It will not happen. What I know, and which I know is likely to cause a barrier to be broken, is trauma. Okay. Any other question, please? Hello, any other question? Okay. Does frequent ejaculation promote competent sperms? Like I've said, these are all introductory courses, the basics. As we move into the sperms and all those things, we'll throw more light on all those sort of things. But you see, physiologically, if you ejaculate more, it reduces the volume of your the ejaculate. And that one, I mean, I'm sure you can explain. Now, as we know later on, it takes up to about over 70 days for sperm to begin to be developed to the full maturity. All right. And so sperms that are stored, and remember, I don't know whether I mentioned it, the sperms, the maturation and everything will happen from the head to the body. The tail end is only for storage. I'm not sure whether I mentioned that, but if I didn't mention it, take it. That from the sperms are produced and then begin to enter from the efferent tubules into the head of the epididymis. And then from that set, I've said that it can take about 14 days from the sperm to travel from the head to the tail end. And within that space, that's where the sperms are going to go through maturation, and they begin to also develop motility. Otherwise, initially they are immotile and nothing, I mean, they are immature. So once they get to the tail end, they are stored there. So it's like, if you have frequent ejaculation, then it means that you got to a point where the matured stored sperms will have been exhausted. So a lot of the immature ones, it's like if, let's say, talking about if you are bleeding, and you know that the bone marrow will have to retain the immature red cells. So, but if you are bleeding, then the bone marrow will be compared to pushing erythroblasts, immature nucleated red cells. So once you are seeing a lot of nucleated red cells, it means that there is some kind of increased blood loss. Understand? So it's like a child with sickle cell anemia. Okay, because of the rate at which they are losing blood, the body will have to compensate that by pushing in more of the immature red cells. So if you have a stored, matured sperm cells within the tail end of the epididymis, and you are ejaculating like almost every day, you are ejaculating, sometimes twice a day, and stuff like that, then you get to a point where the sperm that will be coming, they are all immature. All right, and you can appreciate that immature sperm cells are incapable of fertilization. That's what I know. And of course, as you do the proper semen analysis, not semen, even the sperm production or semen production, you see that we have about 70% of the semen volume is produced by the seminal vesicles. And it's like a gland that is producing fluids. So as you move, as you ejaculate a lot at time, the flow of the or the production of the fluid from the seminal vesicles will also be compromised. And so you get to a point where you are having sex, all right, but even there is no ejaculation. That's aspermia. Aspermia is different from exospermia. Aspermia means that there's no sin, nothing is coming. You are having the exercise, but you yourself you still have to stop because I'm not going to ejaculate. So those are some of the physiological things that we can talk about. But remember, I've said that these are the introductory phases. You zoom into all these aspects of how semen is produced and all those sort of things, and you add more flesh to that. Thank you. Any other question, please? Any other question? Either speak or on the chat. Thank you, Cosby. On that note, we bring today's lecture to a close. We will come back tomorrow, God willing. I don't want us to rush too many things at the same time, because we need to understand these things properly. Like we said before, it's not a workshop, it's a whole course. And at the end of the course, you should be able to know that you have learned something that is impacting on your capacity to even understand semen better, and then andrology as a whole better. All the things that I mentioned are all introductory. We will have time to expatiate on them, especially the hormonal effects, how the hormones work, what hormone will trigger another one to also trigger another one, what have you, so forth and so on. Right. On that note, bye-bye for today. Good night.